Hello, my name is Alex Simmons, and I will be presenting my project on the abuses of biopower and capitalist greed in the American opioid epidemic. Throughout this project, I will address my main research questions of how has the crisis shifted our view on drug abuse and addiction in the United States, specifically with stereotypical views of who abuses them and what addiction looks like in the United States, and what historical barriers or exclusions accompany the availability of resources and treatment in marginalized areas. These questions are important in the anthropological study of culture and biomedical power, as they emphasize the abuse of power within biomedicine and big pharma on marginalized groups. Overall, the opioid crisis in the United States was exacerbated and caused by capitalist greed within big pharma companies, abused biopower, impacted and heightened structural violence, and targeted specific groups for exploitation. To begin, prior to the opioid epidemic, there was a general trust in our physicians and the FDA in approving and distributing pain medication drugs. This is important to note, as there has always been an inherent sense of safety and trust in the system. However, in and following the opioid crisis, that narrative began to change. Opioids are prescription painkillers used to treat chronic pain, and they are originally developed from the poppy plant. Opioid use, specifically that of OxyContin, can cause the release of endorphins, elevate one's mood, and induce a sense of euphoria. Prior to the epidemic, treatment and prescription plans were limited to managing end-of-life pain. However, there was an illegal and unethical transition to using opioids for chronic pain in the hands of the Sackler family and Purdue Pharma. The Sackler family is an American family who founded and owned the pharmaceutical company Purdue Pharma. Since its creation, Purdue Pharma and some members of the family have faced lawsuits regarding overprescription of addictive pharmaceutical drugs, including OxyContin, as seen through these pictures of Dr. Richard Sackler and family. Upon its release in 1995, OxyContin was hailed as a medical breakthrough, a long-lasting narcotic developed from oxycodone that could help patients suffering from moderate to severe pain. The drug was a hit and has reportedly generated some $35 billion in revenue for Purdue Pharma. Its sole active ingredient is oxycodone, a chemical cousin of heroin, which is up to twice as powerful as morphine. Purdue Pharma launched OxyContin with an insane marketing campaign that attempted to counter the nervous attitude and change the prescribing habits of doctors when it came to opioids. The company funded research and paid doctors to make the case that concerns about opioid addiction were overblown, and that OxyContin would safely treat chronic pain for a long-term status. The FDA approved OxyContin in 1995 for use in treating moderate to severe pain. However, Purdue had conducted no clinical studies on how addictive or prone to abuse the drug might be. Yet, the FDA approved a package insert for OxyContin, which announced that the drug was safer than rival painkillers because of the patented delayed absorption mechanism, which was believed to reduce the abuse liability. The FDA examiner who oversaw and approved this whole process, Dr. Curtis Wright, left the FDA shortly after the approval, and within 2 years, he had taken a job at Purdue, being given a commission of around $400,000 for his work at the FDA. Not only did this epidemic target physicians with false claims and motives of capitalist greed, it also influenced who was able to receive treatment or criminalization following the abuse of opioids and shifted the stereotypical views on what the portrait of the opioid epidemic looked like. Current U.S. white patients have the privilege of unparalleled access to prescription opioids, while Black and Hispanic Americans had little to no access to primary care, leaving them to turn elsewhere like that of heroin. These unfortunate racial divides illustrate how racially disparate drug policies and healthcare practices ultimately benefit white patients' access to treatment and further subsequent abuse. These resulting racialized differences between heroin and prescription opioid control resembled those created by the 1986 War on Drugs and led the United States to the highest incarceration rates in the world, with Black and Hispanic men 6 and 3 times as likely as white men to serve time in jail, respectively. In terms of racial divides, there is essentially 2 opioid epidemics in the United States. We have vastly different systems of dissemination and regulation structured around these 2 epidemics, one in which opioid use by Black and Hispanic Americans is a part of a clinical system that is subject to tight government regulation and surveillance of criminalized patients, and the other, where white users are a part of a deregulated private clinical system based on a view of opiate dependence as neurochemically deficient. By creating this view that one side is abusing opioids due to a moral deficiency, whereas the other side is due to a chronic neuroreceptor deficiency, racialized bipolarity comes into the picture by highlighting the ways in which race and class institutional structures are politicized and racialized into neurobiological differences. At the time, clinics were specifically constructed and targeted towards Black and Latino communities in inner cities and those living in poverty, with a heavy emphasis on security and less on quality of patient care, thus creating a stigma around opioid treatment. Furthermore, in the U.S., where insurance coverage and access to physicians are racially stratified, opioid prescriptions disproportionately went to white patients, whereas non-white patients, even those with access to a physician, were less likely to be prescribed, which increased racial differences in the opioid use. Racialized patterns of biomedical treatment are a product of not only income-related disparities in insurance coverage and the ability to pay, but are also the product of segmented marketing strategies in which high-end goods and services are marketed based on the exclusivity of their clientele. As Hansen says in her article, stratification sustains the capitalist individualism of our time, overall targeting minority groups for exploitation. Finally, as previously mentioned, the opportunity for treatment versus incarceration for Black and Hispanic individuals was significantly higher than that of white individuals. For white individuals, rather than arresting consumers, regulators mandated that physicians use prescription drug monitoring programs, that they institute voluntary take-back programs for unused medication, all while passing Good Samaritan laws to protect those calling for emergency assistance during an overdose from drug charges. While at the same time, in Black and Latino communities, many drug-addicted individuals continued to be incarcerated rather than receiving treatment for their addiction. Despite the many unfortunate events that transpired from this epidemic, we must look towards solutions for the future. The first solution includes the investment in harm reduction programs and quality addiction treatment, with that of medication-assisted treatments, behavioral therapies, and relapse prevention. The second solution includes rectifying the past harmful U.S. drug policies by decriminalizing personal possession of drugs and expunging the arrest records of thousands, mostly young men of color. The third solution involves requiring legislators to evaluate if and how criminal justice reforms will affect racial disparities before voting on legislation through the use of racial impact statements, noting that unless we criticize and expose narcotics policies for their racial targeting, they enforce inequalities in healthcare and law enforcement and leave all individuals vulnerable in the face of inadequate attention to public health. And finally, as Metzel brings to light in his article, the fourth solution involves the use of structural competency in healthcare. Structural competency argues that many health-related factors previously attributed to culture or ethnicity also represent the downstream consequences of decisions about larger structural contexts, including healthcare and delivery systems, treatment access, zoning laws, urban and rural infrastructures, structural racisms, or even the very definitions of illness and health. As Metzel states, structural competency addresses these social needs and their links to race and racism, by increasing clinician recognition of the health-related influences of institutions, markets, and healthcare delivery systems. Overall, by working together to recognize the social injustices and structural racism in our healthcare system, we can correct these issues for the better of our future.